All right, everyone. Thank you so much for tuning into today's World Cancer Day panel, featuring our Fellows Forum and editorial board members. We have a really thoughtful discussion planned for today, focusing on ways to improve cancer care on a global scale, including access to treatments in low and middle income countries and barriers to molecular testing. So without further ado, I will turn it over to our panelists to introduce themselves and then dive into the conversation. So Dr. Cariff, I will let you take it away.
Hi, good afternoon, everyone. Good afternoon to all of our viewers. Thanks so much for tuning in for this podcast on World Cancer Day. My name is Dr. Samuel Cariff. I'm the Chief Fellow at the University of Miami Sylvester Comprehensive Cancer Center, and I'm happy to be here with this awesome panel today.
Hey, everybody.
I can introduce myself. Oh, go ahead, Vikas. I'm sorry.
Oh, thanks for having me today. Hey, I'm Dr. Huck. I'm a third-year internal medicine resident at NYU in clinical investigator track, and I'm going to incoming oncology fellow at U Chicago, which I'll be starting this summer. I have a public health research, and I'm originally from Pakistan, so this is a really important topic to me.
I can go next. I'm Matt Hadfield. I'm a third-year hematology oncology fellow at Brown University in Providence, Rhode Island, and we'll be staying on as a faculty member specializing in early phase clinical trials and melanoma.
And I'm Joe Kalis. I'm an oncology pharmacist with UC Health in Colorado Springs, Colorado.
Hi, I'm Rachel Tucker. I'm a second-year hematology and medical oncology fellow at Northwell Health.
Awesome. Thank you, panelists, for introducing yourselves. Let's dive right into it on this very significant day in the oncology and especially global health community. I think it's a really timely start to our panel because we had a breathtaking report that was released by the WHO's research agency, IARC, just a couple of days ago. And during that report, we learned that there will be at least 20 million cancer cases and 9.7 million cancer deaths estimated. And these are according to the most recent data from 2022. What's really surprising is that 5 cancer types, really lung, breast, colorectal, liver, and stomach together comprise about 50% of the new cases and deaths globally in 2022. And we kind of confirmed that lung cancer was indeed, again, the most common tumor worldwide and was the top cause of cancer deaths. These numbers have not changed recently, despite efforts for tobacco cessation and control throughout the globe. What was very interesting was that the report noted, quote, global inequities in cancer services, with most countries failing to adequately finance priority cancer and palliative care services as part of universal health coverage, end quote. So kind of with that background and striking findings, I was hoping to posit to the panelists as our first kind of theme here, talking about access to treatments in low and middle income countries. Are there any trends or developments that you would like to share either from patients you've served, projects you've served on, or countries that you have participated with?
I think I'll kick us off maybe as the pharmacist on the panel member here. I can speak a little bit to patients we serve here in the US and then the levels of difficulty with that and how that might apply to folks in kind of lower or middle income countries. So I think the universal healthcare is an important piece of it. We've got different health systems in different countries and available. I mean, here in the US, we've got resources through drug companies and foundations and grants, but even still, I see many patients who are still struggling to have that access to care from a financial perspective. So I can only imagine how much more challenging that is in countries at different socioeconomic levels.
So I think...
Oh, go ahead.
Oh, sorry. Go ahead, Matt.
No, I was just going to say, I think it's such an important topic. And I think, as we start thinking more about novel therapeutics and therapies that we can bring to our patients, you have to wonder about how you can bring this out on a wide scale platform. And one really encouraging development that I've seen recently and just worked on a project related to is subcutaneous checkpoint inhibitors. So there's been several clinical trials looking at the development of subcutaneous checkpoint inhibitors. This followed, previous clinical development pathways such as rituximab, which is used in multiple hematological malignancies. And there's actually now atezolizumab received approval in the United Kingdom for a subcutaneous version of atezolizumab. So I think, being able to give something like that that's much less logistically challenging could really help expand the usage of checkpoint inhibitors in low to middle income countries. And I think that's, developments like this could really help bring cancer care all around the world, where right now it does tend to be siloed with some of our newer therapies.
Dr. Carey, you sort of alluded to trends and developments, right? I think what's interesting is that a lot of times for LMICs, for low and middle income countries, we often don't have information to what those trends and developments are just because they haven't been surveyed and thought out. In my health management class I took a few years ago, one of the things we learned, one of the adages is that what can't be measured can't be managed. And I think one of the key aspects to addressing lack of access is lack of access to data. But thankfully, at least in Pakistan, where I'm from, there is sort of an improvement in epidemiological data. And there have been some reviews in patients with breast cancer and DLBCL, for example, that find that in marginalized patients, there's actually a lack of patients who complete sort of the optic basic chemotherapy for breast cancer or DLBCL. A lot of time patients like the one to actually complete all their rounds of treatment as well. So I think there are some interesting trends that we could think about.
I think you guys have brought up some really interesting points too, right? Like insurance creates a really great buffer for a lot of our patients. So usually with copays, at least in the US, patients are still able to afford their chemotherapy regimens. But there's still, even in a country like ours, there's still a significant portion that can't afford the rest of the cost. In India, where I'm from, there's really not a big system of insurance, whether it's like universal or private as much. So usually when patients need cancer like treatments, they see an oncologist or go to a cancer center, which require significant travel. But then also all of the cost for the chemotherapy is out of pocket. So just to give like a rough idea for I'd heard of a case with a patient with triple negative breast cancer that had relapsed. And so the treatment for just the initial portion, about 3 months, was about $75,000 out of pocket. That's just 3 months, right? Like who can afford $75,000 when in a low income country, let alone in like a high income country?
I thank you all for your kind of perspectives on this piece. We brought up kind of multiple levels of issues here, right? We talked about the individual level, the payer level, and even at the national level. Our group here is actually working on producing data that can be measured, thankfully, to kind of show access to things like immunotherapy in stage 3 and 4 non-small cell lung cancer, the most common malignancy worldwide. And the goal with that type of research is, of course, to make sure that cost isn't a barrier to equity and access. So that's our kind of contribution to this conversation, but certainly appreciated hearing your thoughts on this as well.
I think another really good point Matt and Wakas also brought up too was oftentimes here we go for IV formulations or subcutaneous formulations for whatever the treatments are. These really require a lot more like infrastructure and resources on behalf of the patients and a cancer center to administer. So trends and research really would change this landscape. So focusing on either increasing dosing frequency or dose intensities, or even switching formulations to something as oral would really help improve access to care.
I think, another thing too that I often think about is, as we start to give more and more novel therapeutics, we have checkpoint inhibitors, but we're starting to give, CAR T, we're giving invariant NK cell treatments, bispecific antibodies that require CRS monitoring. The toxicities are just getting much, much more complicated than just giving, run-of-the-mill cytotoxic chemotherapy. So while we have the logistical challenges of giving these patients worldwide therapies, they also have to have the necessary infrastructure to have follow-up, to be seen by people who are specialized in these therapies enough. But unfortunately, the complexity of these treatments is really accelerating at a pace that's much, much faster than it has been in previous decades. And I think, some of that's going to be educating practitioners around the world to be able to administer these therapies and give them, in addition to just making them logistically available to everybody.
Dr. Hatfield and Dr. Tucker, you both talked about toxicities and dose optimization, and I think we all know sort of the basics of pharmacology is that it's like the dose makes a poison. And when we think about sort of optimizing a dose, usually in phase 1 trials, you aim for the MTD, the maximally tolerated dose, and that's kind of the one you go with, for to phase 2, phase 3, then eventually to when a drug is approved. But often we don't think about, once we have that maximally tolerated dose, is there a lower dose that we can give to patients that would be less in cost to afford that drug, but would have similar outcomes? And there have been studies that, for example, showing like an abiraterone, you can give a fourth of the dose and get similar outcomes for certain cancers. So I think that's something else to think about.
That's a great point.
Absolutely, because if we can getting the drug to a patient, sure, priority one, but the levels of complexity to follow, and if subsequent drugs are needed to have on hand, like tocilizumab for CRS, I think it does create some additional barriers that need to be overcome.
Absolutely. And I think also another principle of pharmacological clinical trials is no matter what the standard of care is, usually you add the next line treatment to it. So no one's going to do a doublet therapy in multiple myeloma when triplets are already standard and we're pushing towards quadruplet regimens. And this is also much harder to implement in other countries. Whereas oftentimes the best drugs and the best combinations really do require like decreasing your doses, decreasing the amount of drugs and the frequency. And it's really not in the best interest of clinical trials and pharmacies and companies like this to create these trials.
Absolutely. I think a good transition in the conversation would be to talk about another big hurdle to bringing cancer therapies around the world, and that's molecular testing. I think anyone who's in oncology, especially anyone who's trained in the last 5 to 7 years, has seen just the avalanche of new FDA approvals for targeted therapeutics, and I see this as a huge avenue to bring promising therapies to patients around the world. These are oral medications, but they rely on finding, genomic driver mutations. Sam talked about how lung cancer is the most common malignancy worldwide. I mean, EGFR mutations occur in 20% of patients with lung cancer, but there's a plethora of data out there that outside of large academic medical centers, the amount of whole exome sequencing drops off precipitously, and in patients even in our own country, we're not doing a good enough job of getting them tested for driver mutations and getting them access to targeted therapies. And I think that's a huge problem worldwide. I think we need logistical ways to get people tested. I don't know. I would love to hear all of your thoughts. I don't know if that's more blood-based testing with ctDNA and not requiring archival tumor tissue, or opening up access that way. But it's certainly, we're never going to get therapies to people if we can't get them tested for the appropriate mutations.
Dr. Hatfield, I think this is a really important topic, and I'd like to spend some time on it because when I think of this question, I think there's actually two parts to it, right? So the first is costs, and we've been addressing this already in the talk, and we'll continue talking about it for years to come. But the cost of NGS testing, even though it's become more "quote unquote" cost-effective in high-income countries, is still just too burdensome for a lot of single-payer systems, especially in low-income and some middle-income countries as well. Now, some countries are able to get around that. For instance, in South America, they'll have kind of limited NGS panels, or they'll substitute things like IHC and PCR testing for specific targets, for instance, in non-small cell lung cancer. And these might be cost effective, but as we know, you won't find the zebra NTRK or RET mutation infusion here and there, and you do limit therapy options in those cases. So there's got to be a healthy balance between cost effectiveness and availability and access to patients. So I think that's a really key point that really everyone globally needs to keep an eye on, because if we're looking at cancer as this global problem, it needs kind of all hands on deck sort of thing. Now, the other point to this, of course, would be supply chain issues. You posited, should blood-based testing maybe kind of come in the way when we don't have archival tissue? I think that's a wonderful idea. Of course, the problem is the infrastructure, and a lot of these private companies that are still kind of in the equity space haven't necessarily extended those supply chains. This is so crucial to make sure that patients from any country, whether it be LMIC, high-income country, wherever, have access to kind of standard of care therapies in other sorts of countries. So if I had a perfect world and could do whatever I wanted with my budget, I would really love to see more cost-effective ways of balancing NGS approaches, and also making sure that supply chains were present globally if possible.
I think another aspect to targeting your NGS testing is putting your money where you're going to get the most bang for it, right? So if you have certain populations that have a higher mutation of something, that really should be indicated in like certain countries, and like other tests, maybe not as much if you don't have that incidence. But I think another problem we run into in this situation is a lack of diversity in clinical trials. And if we can get more diversity into clinical trials, it would also help us realize, oh, these genes are much more important in this like certain region, and these would be more likely to respond to certain treatments. So I think the more diversity we can bring, it would also help create better targeted molecular testing too, like based on populations.
I'd advocate perhaps for some more standardization across testing. You know, we've mentioned lung cancer several times as a very burdensome malignancy worldwide, very high mortality rates. And I think back to checkpoint inhibitors, atezolizumab, pembrolizumab, et cetera. When those are all released, they each came with their own diagnostic to evaluate for PD-1 or PD-L1. I know we're speaking here more on NGS testing, but if we can incorporate a lot of that into maybe one panel, whether it's archival tissue, whether it's blood-based, I think that could offer some opportunities where, depending on costs and access and supply chain, but if we only need to run one test and can get a lot of actionable information from it, that may offer some advantages.
No, I think those are great points, and even to circle back about some points made previously, you know, you can't fix what you can't measure. I mean, we don't even really I don't know this data very well, but you know, I would imagine and I would presume that most of the whole exome sequencing data that characterizes populations comes from places like the United States and Europe, and we probably don't even have very good molecular characteristics of different genomic alterations in lower income countries. So, I mean, until we characterize that more, you know, we may be missing higher prevalence of mutations in those places and not treating it appropriately. But, you know, as Dr. Cariff mentioned, you know, the logistical aspect of getting this done is the biggest hurdle.
And I think another aspect we also haven't tested on with genetic testing is just the other infrastructure you need in addition to just the sequencing. So oftentimes if we have patients with breast cancer and we do BRCA testing or ovarian cancer, you really need a good genetic counselor for these patients too. And a lot of like low and middle income countries don't have access to these. And I feel like this is probably another area where we could use telehealth to at least increase the span of the genetic counselors we already have. But I mean, the problem is it's one simple solution isn't going to fix this. We really have to come up with a huge interdisciplinary approach. And I think another aspect is we have an oncologic pharmacist and 4 medical oncology fellows. We're really focusing on like the medical oncology side. There's so much that we also have to do with radiation oncology, surgical oncology, and also palliative care.
Yeah, Dr. Thacker, I think that's a really important point, right? Because we see a lot of different approaches taken by different players in the field. Maybe the more traditional universities often engage in these kind of partnerships with select locations, hospitals, countries, and that sort of thing. And they're excellent partnerships, though limited, of course, because of just, you know, people power, budgeting, that sort of thing. Governments also step in that role as well. The US, the EU, et cetera, often create programs in terms of funding, project development, et cetera. Again, these are maybe larger in budget. And then maybe slightly more directed in terms of funding. But really, I mean, we can think of so many other players who necessarily could be kind of assisting, right? Patient advocacy programs are now existing on a global scale, and they're existing to help kind of connect folks with cancer with kind of local resources that these patients might not have been aware with previously. We can think of non-governmental organizations kind of stepping in to chip in as well. And even for-profit healthcare companies, right? If there's so much access to these therapies in high-income countries, why not pilot them in low and middle-income countries to try to expand either for profit, but at the end of the day, really helping to benefit patients. So I would love to see a lot more movement in this sector if possible.
Great. So as we wrap up the conversation, any other points that anybody would like to make?
Dr. Hadfield,
No, I think
you mentioned you were talking about disparities and you sort of at a local level, and I think that's a great point. That when we think about global health, that disparities don't start abroad; they actually start in our own locales. And even if we want to treat or sort of get involved in global health, we should always ask ourselves what we can do with this sort of institution we're affiliated with to maybe sort of find improvements or find ways of getting involved in global oncology. One of the access to data for this is the 2021 Global Oncology Survey. Events at cancer centers actually found that over 90% of cancers do have some kind of global oncology involvement, which is great. And over half of them involve some kind of global oncology training, which is also excellent. But if you look at the most common countries that are kind of involved in AIH-associated cancer projects, they include countries like Canada, UK, Germany, Australia, not really your typical sort of LMICs. So I think when it comes to global oncology, first, like let's try to aim for a more equitable distribution of countries that we get involved with, sort of creating research programs and fellowships with maybe LMICs as well. And then the second thing is, I think, just the importance of cultural awareness. Like, you can't just throw money at a problem and just fund trials. You have to also think about sort of cultural awareness, sort of people's, beliefs, their perceptions. In Pakistan, where I'm from, there's like a lot of alternative medicine. People go to shamans, things like that. So that's the thing that just providing access to clinical trials is not going to solve.
I think
Um,
that was really really great points that you just made, and I think to piggyback off what you're speaking about, and why I think it's so important is that we have to like act locally but think globally, and that's something that here in Providence, we've been really trying to bolster our outreach programs in terms of screening and reaching out to at-risk populations. But we actually have a very high population from Cape Verde here who is actually in the category of patients who have the least amount of cancer screening in terms of cervical cancer, so that identifying who you could help locally is big, but also to be piggyback off one thing that you just said that I think is so important. We can throw money at trials, but we have to keep having conversations about diversity in clinical trials. It's been shown time and time and time and time again that phase 3 trials are very homogenous. And if we want to bring access to cancer care around the world, we have to also think about how to make those trials reflect world populations, and that's incredibly important. And it's not an easy fix. There's a lot of moving pieces, but it's something that we have to keep talking about.
To build on those excellent points, my kind of take-home message from today would be to remember global health is public health. I practice in Miami and South Florida. We're one of 2 North American localities that are over 50% foreign-born, meaning more folks are born in areas like Latin America and the Caribbean than within North America itself. So on a day-to-day basis, I'm constantly thinking about things like prevalence of EGFR mutations, access to care outside, are there clinical trials in other countries, that sort of thing. So I guess I would plead to the listener from maybe the United States, Canada, or another high-income country that this affects you as well, right? Because maybe it's not affecting your day-to-day life, but it might affect your tax-paying money. It might affect the way that patients are cared for if they seek care in an institution near you. It matters. You matter. So thanks for listening today.
And to also add, I guess my take-home message out of all of this is really like the 5 of us can't fix everything. It's way too much to get access to every person in the world. But the least we can do is start small, whether it's increasing screening so patients are caught earlier, just starting in your own backyard. Like the smallest steps you can make would really add up over time.
Any other parting thoughts anyone has? Great. Well, thank you so much for such a thought-provoking conversation today about the ways that we can address these barriers and improve cancer care throughout the world. So we really appreciate hearing all of your powerful insights. So thank you as well to everybody for listening today, and be sure to check back throughout the month of February for some more interviews and panels from our team that we have planned, including another live YouTube panel on February 29th for Rare Disease Day. So be sure to follow us on YouTube and social media, and visit oncdata.com to stay updated on all these latest events. And thank you so much to everybody again, and have a